All right, everyone, thank you so much for joining us. Feel free to continue to drop in the chat where you're from and what class and what school you were at Emory if you would like to. But welcome to Equity, Health, and Justice for All. We're so excited to have you guys today. My name is Dominique Harper. I am an assistant director for alumni services on the leadership engagement team, and I am going to introduce Dr. Jada Bussey-Jones for you all today, and we're going to jump right in. So we're going to go through the presentation and then we're going to save about 15 minutes at the end for questions. So hang on to your questions or feel free to put them in the chat and we'll review them at the end. All righty. Okay, so Dr. Bussey-Jones is a professor of medicine in the Department of Medicine of Emory University School of Medicine. She received her BS in sociology and later her MD from Emory University. She currently serves as the Chief of Grady General Medicine and Geriatrics, the Vice Chair of Diversity, Equity, and Inclusion for the Department of Medicine, and the Associate Dean for Professional Development for Emory at Grady. Dr. Bussey-Jones has nationally recognized educational expertise in the areas of minority health, health equity, as well as patient and provider education. She has developed several program initiatives addressing health promotion and disease prevention for vulnerable populations. She developed and directed curricula on cultural competence, disparities, and social determinants of health for students, residents, and faculty, and was recognized with an Educational Innovation Award for this work. She has chaired the National Disparities Education Task Force for the Society of General Internal Medicine organization and served as editor for a special issue of the Journal of General Internal Medicine dedicated to disparities education. In this role, her leadership resulted in an award-winning National Disparities course, web-based educational modules, and national symposia on disparities at both the Society of General Internal Medicine and at the American Association of Medical Colleges. In 2023, she was recognized with the AAMC GDI Exemplary Leadership in DEI Award. She's the current president of the Social of General Internal Medicine. Wow! This lady is amazing. No, but without further ado, I'm going to pass it over to Dr. Jada Bussey-Jones. And I want to say again, thank you all so much on behalf of the Black Impact Circle for being here.
Thank you so much for that really wonderful announcement and introduction. I am telling you, that's probably going to be a little longer than the presentation. Just joking, but I really do appreciate that, and I really appreciate all of you taking your time out to feel this Emory love this evening and talk about health equity and justice for all, a topic for which I have obviously a great deal of passion and spent some of my career thinking about this. I don't have any financial relationships to disclose, but, I will be talking about race, and I will be talking about race in terms of a socio-political construct that it is, not biologic or sort of genetic essentialism, but we will be talking about some of the determinants of health. So what I'm hoping is by the end of our time together, you'll understand what health equities or health inequities are, some of the key drivers, how it's related, some of the evidence around how it plays out in our clinical spaces. I don't know if I have other physicians or clinicians on the line, but whether you are a clinician or a patient, or even working in a company, how these issues may play out in our day-to-day lives, and importantly, some strategies that we might use to kind of mitigate the impact of our biases. So I will ask you guys to use the chat a little bit to answer some questions. And at the end, I'm hoping you'll be able to come off mute some. But I'm going to start off with a case. I do this with my learners. The case is a 36-year-old Black female who comes in with a pulmonary embolus, a blood clot in the lungs. And she has a history of that. And she comes in with labor. She's about to have a child. She undergoes a C-section, and she's doing well after the C-section until the day after her procedure, when she starts to experience chest pain and shortness of breath. And because of her history, she says she thinks this feels like her last pulmonary embolus or blood clot in the lungs. She asks for the same test and treatment that she got last time. So then I ask my learners, what would you do next? And they say, well, you know, of course she is at high risk for a blood clot because she's had one before. She's peripartum around pregnancy, which makes her at high risk. And her symptoms are classic for a blood clot in the lung. So we would do the tests and the images that she's requesting. But that's not what happened. That the nursing staff and the physicians that were caring for this patient thought she might be a little delirious, perhaps. Maybe she had been getting some opioid medications to help manage her pain. However, so they thought they would just give it some time and they would wait. The patient continued to sort of ask and plead for this diagnostic testing, and and after some time, after pleading with the staff, the imaging and the testing is done, and it does in fact confirm what the patient suspected as a diagnosis, that the patient had multiple submassive pulmonary emboli or blood clots. And so I want to ask, this is a true story, a real case. Does this case sound familiar to anyone? You can put it in the chat. See if anyone has any idea of who this happened to. Yes, exactly. So Serena Williams. And so my point here when I think about this information is that if it could happen to Serena Williams, I don't even know if she has insurance. Maybe she doesn't need it when she has this kind of money. But you know, if she wanted insurance, she could pay for her services. She has prestige and power, and people know who she is. That if for whatever reason that in that situation she could not be heard, whether it's gender or race or some other thing, that it could happen to any of us on this call, the patients for whom I provide care at Grady Hospital. So this is one of the reasons why this is important. So we also know that their diversity is increasing in the United States, and by 2050, the majority of our US population will be non-white. And so issues of caring for this widely diversifying patient population are important. And so we have to continue to think about how these issues impact our profession. In my case, health profession, in all of our cases, our communities and our patients. And I will ask all of us, whether you're in healthcare or not, to think about what we can do as we're moving forward. So I'd also like for you to put in the chat, if you can think about any issues that might be coming into play. And I don't know if they can come off mute, but if there are any issues that may come into play about why there might be inequities in care or differences in treatments or outcomes or anything like that. So any thoughts about that? Anybody want to offer a guess in the chat? Bias, okay. And that perhaps was the case for Serena. Any other thoughts? No empathy. And I hear this, again, even as somebody who is a physician, I hear sort of lack of empathy, lack of listening sometimes in the healthcare profession. Access issues may be big as well. Those are really important things. Differences in medical training and perspective, thinking about the textbook and not the person. I love that, and I definitely agree that that's true. Myths about Black women. Yes, bias about differences in pain. And so all these things, you guys are coming up with some really great ideas. Power and race. That's deep, Jennifer. So yeah, so I think all of those things are playing out when we think about health and well-being. So if we start at the end of this slide here in the purple circle, the goal is health and well-being. And when you think about inequities in health and well-being and you move more proximate, the issues are varied. So we can start at the top with sort of my field, and some of you I saw are in the public health field, healthcare, public health. You can think about issues related to neighborhood and built environment. So if people don't have housing, or if they're living in a home that is in a food desert, or doesn't have sidewalks, or there is pollution or lack of an environmental canopy, and at risk for weather-related events, all those things play out. There's education that leads to economic stability and lack thereof. But what is the proximate factor for there? If you go even more downstream, there are laws and policies and procedures that lead to these systems and structures, right? And that those things are built, to some of your points in the chat, that they're built on the root cause, which is structural discrimination. Racism, we can talk about, and that is clearly one of the major things, but it's also sexism, it's also ableism, it's also classism. But all of those things over time have led to the laws and the policies and the cases that drive sort of why we do and don't have healthcare. Expansion of Medicaid, for example, and why some schools, even public schools, are better funded than others. And so those are oftentimes driving these disparate outcomes. The thing that I wanted to show in this slide is that it's humbling as a healthcare professional to know that what we do in the healthcare space is really the smallest percentage of some of these of the determinants of overall health, right? So even if I come up with the right treatment plan, the right diagnosis, that if the patient can't afford the medications that I prescribe, if I want them to have a Michelle Obama DASH diet that's high in rich and fruits and vegetables, but they live in a food desert, then they may not, I've asked them to walk, but they don't feel safe in their neighborhood or their streets don't have sidewalks. Then there are other things that lead to poor health outcomes even before they come to the physician or to the doctor or the healthcare system. So that's just a brief introduction to sort of what is driving the inequities. Now I'm going to talk a little bit about some of the evidence around how how these inequities play out in our spaces. So I'm going to start off with just a basic definition of bias. I saw someone put that in the chat. So you all probably already know this, that biases are just differences that affect the way that we understand the actions that we take, the decisions that we make, but it's important that they are implicit. They're not conscious. Nice people have biases. We all have biases. The important thing to think about is that they are pervasive. They are in the metaphorical air that we breathe as members of U.S. society. They are unavoidable, and they don't always align with our declared beliefs. So if, for example, you were out marching in Black Lives Matter protests, a few years ago, it is still very likely that you have anti-Black bias. Because you have breathed the US air or, that metaphor. Also, even if you are Black, you identify as Black, that is also very likely because we internalize these biases and we are breathing the same metaphorical air of society that we are often likely to have anti-Black bias, or as a woman, anti-gender related bias. So you internalize the sort of biases of the larger society as well. So if you will bear with me, I'll share a little bit of my own biases, the story of my own biases. This is me when I was a baby. And I show this picture not because I was such a cute baby. I often joke that I know that's what you're thinking. But this is me with my grandparents outside of their home. I think it was at Easter or something like that. But I am a descendant of people who were enslaved. So my grandparents' grandparents were enslaved. My grandparents that you see here, the legacy of structural racism meant that in this rural segregated town of Georgia where they lived, they could not attend high school. So they went to 6th or 7th grade, which is the largest, the only school that they had for Black students. And then they went to work. For this story and for me, I spent every summer of my formative youth in that town. And I talk about a railroad track that was both a physical and metaphorical divide. And I have no doubt that my experiences in that town on both sides of those railroad tracks color the lens, for better or for worse, through which I see my patients, my colleagues, my learners. And so I would argue that while all of our stories may be different and unique, that I'm not unique in having biases, right, or having a perspective and a lens through which I see the world. And researchers suggest that, we don't come out of the womb on day one with these prejudices, but by 3 months, we begin to develop these preferences, and then they get embedded and indoctrinated over time, this metaphorical air that we breathe, right? So whether it's television, old school radio, newspaper, internet, AI generated tools, this is just a Yahoo search that shows images of a doctor, another one that shows images of a boss. I identify as both of those things, and I don't see myself represented in those images. And you might argue, well, those are, not real. Maybe they're, Google AI kind of things. But if I look at real images of leaders, so you can identify the ones on the bottom as our presidents of our country over time. And the ones on the top, you may not recognize. These are my leaders, every leader that I've had since I've been on faculty at Emory School of Medicine. And so these images provide real, clear, if unspoken messages about who leads, who's included, and who's at the table. But I am happy to say, though, that for the first time, it's been just a few weeks now, we have our first ever woman dean at Emory School of Medicine. So there are still opportunities there. So I'm saying that we have this air that we breathe then over time in our society. It would be nice if I could say that, I'm a professional. I don't let those things impact my clinical environment, my work environment. I can have my implicit biases, but I don't let them play out in terms of the care that I'm delivering. But unfortunately, the evidence suggests that that's not true. There was a large-scale Institute of Medicine report that showed that across healthcare, that minorities receive fewer procedures and lower quality care than whites, and that those differences persist even when you control for things like insurance status, socioeconomic status, the stage of their disease, the places where they receive care. So, for example, in a VA system where the veterans had the same job, the same insurance and access, that there were still statistically significant differences in their health care and their healthcare outcomes, like receipt of mammograms and things like that. And then they've done a lot of audit type trials, that's what they call them, where you can see the images of here on the left side of actors who were playing the role of patients. You can see they're all in the same hospital gown, they have the same background, they were instructed in the same script that described their chest pain, their job, their insurance, everything exactly the same. They even directed them in their arm movements. And they showed these video vignettes to groups of physicians who were attending a national meeting, and then asked those physicians to tell what their diagnosis and treatment plan was. And they found that even though objectively the information was the same, that their treatment recommendations differed based on race and gender. And so I could go on and on about that because there are lots of studies that have showed similar findings. My real question is, how does this happen? Because I think, I'm a physician, I work with lots of physicians, and I think that by and large, really wonderful people. No one sits in an office saying, I'm going to treat this patient differently because they are green or polka dotted, purple, whatever. So how can well-intended physicians end up providing disparate care? And so Michelle Van Ryn is this clinician scientist who has this really elegant, conceptual framework where she describes how this can happen. And I won't go over through all of this, but I will just say a couple of things that sort of resonated with me. So first, she says that how we interpret symptoms might be different based on our biases. What we believe to be true about a patient may even change how we hear the story. So I'm thinking about Serena Williams, for example, and how we perceive someone when they come in with chest pain that sounds like classic, from the outside looking in, blood clot to the lungs, but how we might interpret those symptoms differently. She also demonstrated studies that talked about even our interpersonal behaviors may change, not just based on race and ethnicity of the patient, but also gender, age, so-called attractiveness. I'm not sure how they determined that in this study, but they looked at videotaped encounters of physicians and patients interacting and found that there were lots of things that drove physician behaviors, interpersonal behaviors. So how much nonverbal attention, like eye contact or physical contact, how many statements of courtesy, like please and thank you, or statements of empathy, like I'm so sorry that happened to you, or even how much information you give altogether. And so here I can imagine I might write the same prescription for a blood pressure medication for a patient, but if I have not engaged with them empathetically, as I saw in the chat, that it may change whether and how they adhere to the treatment recommendations that I've made. And then lastly, our clinical decisions may be based in part on our biases. Here she cited one study where anti-HIV medications are prescribed primarily, this is true, if we, they don't like to prescribe anti-HIV medications for patients who might be non-adherent because, or not take their medications, because if you stop and start the medications, the virus can build resistance. It can be even more difficult to treat. So they looked at cases, made up cases, to see how did they predict physicians, how did physicians predict adherence, likelihood of adherence. So the cases were the same, and they found that physicians rated Black patients as more likely to be non-adherent than their otherwise identical, other racial counterparts. So they looked at lots of different characteristics, but they found that Black patients were likely to be rated as non-adherent. So here again, our biases as physicians may end up causing differential treatment. I may make an assumption about whether someone is going to take the medication and not prescribe it, not giving them life-saving care. I may make assumptions about whether someone has literacy level or can understand a complex treatment plan and not prescribe or put them on a transplant list. So those are just some examples there. So unfortunately, our biases may be playing out in our clinical encounters. I'm going to move a little bit to our job and our workplaces. I work in academic medicine. I would argue that many of these things are also applicable, unfortunately, in Fortune 500, sort of traditional work organizations as well. I'm going to start again with another case. The case is a Black woman who's an associate professor who's been in rank for 6 years. She goes to her leader and requests consideration for promotion. The leader says, I'm thinking about you. I don't want you to be disappointed. I think you should wait. And just like in the case of Serena, this is a real case. This actually happened to me. I know because it's real. It happened to me. And I will say, in fairness to my leader who had actually hired me, been mentoring me, legitimately was concerned about my well-being and wanted to support me, but there was bias there, unintentional and implicit bias that may have impacted my career trajectory. He made an assumption without looking at my materials. I had been serving on this promotion and tenure committee, so I just asked him, nudged him a little bit more to look at my information, and he did and was able to put me forward. But this, this is not, I'm not alone in this either. There's lots of evidence around women, faculty of color, professionals of color, having less mentorship, more experience of biases like the one that I just mentioned, and as a consequence, in academic medicine are less likely to get promoted, report lower levels of job satisfaction, and may leave academic medicine altogether. So just to give a little bit more evidence here, so this is a study that was done at a research intensive institution where they ask researchers to look at student applications for a lab manager position. Here is another made up case essentially where they had the same CV, cover letter, same experiences, same education, everything exactly objectively the same. The only difference in this case was that some of the packets were given the name Susie and some given the name John, so male versus female. They asked the faculty who were looking at these applications to judge the students in terms of their competency, whether they would hire them, whether they were interested in mentoring them, and how much salary they would give. And what they found is that the male students were statistically more likely to be rated as competent, hireable, and worthy of mentorship. And similarly, they wanted to pay the male students more. And interestingly, if we go back to this idea of internalized bias, that the women faculty similarly rated the male students higher. So this idea, again, of the air that we all breathe, the metaphorical air, that sort of helps us to know, or when we think about what a leader looks like, in this case, what a good applicant looks like, even if you might be in the other gender. Letters of application or letters of recommendation also reflected gender bias in the study of over 1,000 postdoc applications. They found that male letters were just stronger, longer themselves, had stronger language like brilliant scientist or one of the best, whereas the women letters for women were fine. They tended to be shorter and didn't really help them to stand out from others. And then those are sort of studies that look at getting the job, getting in the door in the first place. But even once you get the job, this study looks at over 80,000 performance evaluations and found that there were just gender differences in the way that people are evaluated. The items in blue are more positive terms, and the items in yellow are more negative terms. You can see that there are differences, and also the words themselves are different compared male versus female. And then, the other thing about being in the job, not just the evaluations, the day-to-day experiences that people have when they're in the job setting as well. Microaggression, some people do and don't like this term, but if you've heard about this, these are brief, usually verbal indignities that are unintentional. Sometimes people actually mean to say something good. I had one in black. There is one that happened to me, like that presentation was surprisingly good. You speak really good English. So someone might actually be trying to give you a compliment, but what they're doing is telling you they expected something different, or where are you really from, which is kind of othering, and that kind of thing as well. I would be happy if anyone wants to share any examples of microaggressions in the chat. I'm going to move forward, but sometimes I like to get examples for my future talks, but those are just a few that I've heard before. I'm going to share with you a video now of something that is both a microaggression and an internalized bias, and see if you all have any thoughts about this. I hope the sound plays well, but let's go see if we can do this.
Hi, Erin. Show me what it looks like to run like a girl.
My hair.
Show me what it looks like to fight like a girl. Now throw like a girl.
Aw.
So do you think you just insulted your sister?
No. I mean, yeah, insulted girls, but not my sister.
My name is Dakota, and I'm 10 years old.
Show me what it looks like to run like a girl. Throw like a girl. Fight like a girl. What does it mean to you when I say run like a girl?
It means run fast as you can.
So I know that was an always commercial, but it does really demonstrate this idea of internalizing biases. So these younger girls have not yet internalized what doing something like a girl means and sort of the negative connotation that goes along with that. But I love, thank you guys so much for the examples that you put in the chat. Wow, you went to Emory? Okay. Thanks for sharing those with us and being vulnerable. So I'm going to go to the last part, which is perhaps the most important part, and which is kind of what are some solutions? What are some ways that we can mitigate the impact of this? And you know, hopefully there'll be time at the end for you all to share any of your thoughts and strategies as well. I like to start by saying that diversity itself can be a mitigating factor. I used to make this argument from a social justice framework. You know, it's the right thing to do, you know, and it's true that it is still the right thing to do to have a group of professionals, in this case, physicians and healthcare professionals that represent the population that we serve, right? But I also now, especially because as I've become a leader and I'm talking to other leaders, have talked about how it relates to you know, having a better workplace, having a better bottom line, talent management, and providing better care to patients. And there's evidence to sort of support that, right? So long before we started thinking about this in the healthcare space, there are, you know, things in Harvard Business Review and McKinsey that talk about for every 10% increase in gender diversity, there's a 2 to 4% increase in profit. If you have at least one woman on the board, increase in profits. It makes intuitive sense that for that increasing diversity is also associated with more innovation. When you have more different minds thinking about a problem or a solution, that you can come up with different innovative techniques. But if I narrow to sort of my book of business in healthcare, that there's some emerging evidence here too. The first slide is about gender. The next one is about race. But you know, there's studies, for example, that show that women are less likely to die after an MI if they have a woman physician. Women are less likely to die after a surgery if they have a woman surgeon. Also, just in general, women physicians are more likely to follow guidelines. There are lots of guideline-based care for diabetes management, heart failure. Women kind of follow the rules a little bit more, at least according to the study, and that women are also more likely to engage around. I heard someone say that you know, the empathy sort of beyond the medical care or the textbooks, more about social circumstances and spend more time with patients to understand who they are. And then when you think about some of the racial diversity, so Black patients are more likely to get preventive services like mammograms and flu shots when they're cared for by Black physicians. Here, one of the studies I'm thinking about, when they showed the images of the Black physician, that wasn't enough, that they didn't sort of agree to a flu shot, for example, just seeing a Black physician versus a white physician. But after the encounter, they were more likely to have gotten the flu shot when they saw a Black physician. And the authors noted that, you know, the Black physicians, again, were more likely to write things about their social circumstances. Perhaps those statements of empathy, the interaction may be different when there is race concordance. We also know, like myself, I wanted to come and work at Grady. I didn't know anything about academic medicine. I had to join faculty at Emory in order to do that. But many Black and Brown faculty want to come and work with patients that are poor and vulnerable, Medicaid populations, minority populations. So that is, I think, a benefit. And also, there's a fair amount of evidence around race and language concordance, as I was just talking about, that's associated with improved patient satisfaction, more adherence to therapy, higher ratings of trust. There's a study that linked better infant mortality or lower infant mortality when the race of the physician matched the race of the mom. And then finally, one additional study that I want to highlight, mostly because I am a primary care provider, so I'm like, this is awesome, I'm really happy about this, is that, you know, having counties with more Black primary care providers has been associated with longer life, so longer life expectancy in these counties. The sad news here is that they did a nationwide study that there less than 50% of all US counties have even one Black primary care provider. So that's kind of sad. However, if you do, or the counties that did, that there was an increase in life expectancy, and the impact was higher for more impoverished people. So in other words, there was an improvement for everyone, but the folks who were had higher poverty rates actually had the biggest impact of having more Black physicians. And the other thing that they noted is that you didn't have to necessarily see the Black physician. So it wasn't that all the Black patients were going to the Black physicians, but they assumed, or they thought, that it may be something about, first of all, Black physicians wanting to live in a community. So that may say something about the environment itself, that a Black physician would want to come and raise their family, but also that Black physicians may be doing other things, you know, in terms of advocacy and engagement in the community outreach that is beyond the clinical encounter that we just talked about. But either way, having more diversity, this is my point, can improve the health overall. Other things that we tell our learners, there's emerging evidence around this, and I think it may be applicable to some of our other professional settings as well, is this idea of, you know, humanizing, and you all talked about this too, humanizing our patients, not thinking about them as a diabetic in room 22, understanding more about them, you know, whether they like the Braves or trying to make a connection, understanding more about their background. This idea of perspective taking, it seems a little bit cliche, like putting yourself in the other person's shoes, but, you know, somebody mentioned about pain perception. So there have been a lot of studies about nurses in an emergency room after someone has an acute femur fracture, right? So that's a situation where it should almost be inarguable that someone would be in pain. Like, you just broke your femur, which is your thigh, like you would be in pain in the emergency room. But if you ask the nurses to think about how would you want to be treated in this situation, that was found to mitigate the impact in their treatment of the patient's pain. So to try to, it mitigated some of the inequities in treatment. The other thing is just, you know, taking time and thinking intentionally about our biases. We do a lot more bias training so that people first are aware that they have biases. Also, I don't know if any of you have done the Harvard Implicit Association test. It is a validated instrument to actually examine your blind spots. I know I have some around BMI and body mass index or obesity. And so when you have someone that may be triggering, I also had some internalized biases, mild preference, pro-white preference, which was surprising, but not so much, that I've had to work on as well. But importantly, when you find that you have biases, or even if it's just someone that you're not connecting with as a patient, those are the patients that we need to spend more time. And that we know that when we're rushed or when we're hungry, and so those patients I might schedule at the beginning of the day, I might see when I know I'm going to have time and I'm less rushed, and I might think intentionally about my biases so that I don't act on them. And that's been found to be helpful as well. The other thing that's kind of, I don't know, it's a little sad to me, is that when we take the physician's judgment out of it, that's actually been found to be helpful. So with nurse-led interventions that are more protocol-based, where you literally have a list of things that you do for everyone, to sort of evaluate them, whether they are a transplant candidate, to evaluate them in terms of how you're managing their diabetes and their heart failure, so that everyone has, that we really sort of check off the boxes and allow other team members to help us to make sure that everyone is getting the standard of care. I'm going to talk a little bit about some work that I've done in the professional space and then try to give you all a chance to engage a little bit. I'm really proud of some of this work in terms of, based on my experience, again, when I became a leader, and I didn't want for my biases to limit the trajectory of any of the folks that that were reporting to me in terms of their pathway for promotion. So I started a program that I'm not going to tell you the details about. I'm just going to show the outcomes of this program, but we proactively look at people to prepare them for promotion. This has been published in the literature. But I will tell you that when I started as a leader in 2013, there was only one white woman who was a full professor. I'm just calling your attention here. So 0% women URM faculty were full professors. In 2020, when we sort of wrapped up our study of this, we had 25% of our URIM, historically underrepresented Black and Brown faculty, were full professors, and 19% of our women. And then we thought, well, maybe it was just time. Over time, people are going to grow in their careers. But then we looked at our School of Medicine and the entire AAMC, like across the country, to see for comparison. We saw that there wasn't a similar trend in terms of improvements in rates of professorships or getting promoted. So it really was the intervention. And now we have the majority of our faculty in my division have been promoted. And that means 65% of our women, 48% of our URIM faculty. This is unparalleled across academia. Also, white men are promoted, so this is impactful for everyone, but there was a disproportionate positive impact because historically, women, people of color may be less likely to self-promote or to ask for promotion and for their works to be seen because we are proactively now looking at this. And again, looking at this nationally, now there's about 1%. When I first did the slide, it was 0% of all professors in the country were Black women. That includes historically Black colleges, by the way, the Meharys, the Morehouses, that now it's about 1%. We are at about 1%, but now we have 5 Black women full professors that are, in my small division based on this intervention. Also trying to mitigate my biases, I had to start evaluating not only my leader who I was talking about earlier, but also my friends pictured in the ones that I just showed. And so I wanted to sort of figure out how I could be more unbiased. So I just made rubrics for everything. People started asking me for things. I was like, let me make a rubric for that to understand and be transparent about how I'm making decisions. So this, for example, talks about if you want to get an exemplary on your annual review for scholarship, you have to do 5 publications, have a grant, or get a research award. So, but really for everything, for space, for salary, it's not that people don't have different things, but there is a clear understanding of how those decisions are made. And they can actually write their annual review based on the rubric for the most part. And we just talk about how to move forward. I started to have transparency around opportunities. This has been big. So I always have an idea of who would be great for a new leadership role, but I always open it up to have an open call for leadership, have a committee who's selecting. It's not just me. And about 50-50 of the chance of the time now that the person I thought would get the role actually gets it. A lot of time it's not the person that I thought. But having this really helps to minimize or mitigate this idea of people thinking that they're being excluded. I also am transparent about sort of a diversity dashboard that not only includes our diversity, but also how people are progressing, how many professors, how many leaders. And I did this for our entire Department of Medicine. If we have 70% of our division are women, but only 10% of our leaders are women, that's an opportunity. And looking at that transparently is really important. And started to build some of these programs across the institution as well. So I am fortunate to lead and have started a underrepresented in medicine professional development program. In our first year, 11 of the faculty were promotion eligible. They had been in rank from 5 up to 18 years. And after this program, 81% of them were promoted within 2 years. What this meant to me is that, I didn't change what they were doing, their research, their other work that they were doing, but the intervention really just named promotion as something that was important. It increased their confidence and their fear of rejection. Some of them had received past bad advice like I had and lack of information. And so we were able to really propel them towards success with this intervention. We've also worked to change the curricular content across the School of Medicine so that we begin to think about some of these things. Like I said, medicine, diagnosis, clinical care, it is the smallest part of health. And so we want our next generation of leaders. When I was a medical student, I spent 8 hours a day learning anatomy, chemistry, all those things. Now we can like look on our phone and get that information. We have to learn how to talk to people, how to engage communities, how to work with legislators, but really understanding, sort of how these things interplay with the health. And we've been able to build a course that went initially from an elective to a required course. It became a graded course. That's how the students really pay attention. And now it's a featured course. It's one of the seminal things that our medical students look for when they come to the Emory School of Medicine. And then finally, I think that I've been able to build an advocacy course. This is one I believe the first in the country, at least there's no one that's published about an advocacy course, where we train our faculty to think about how to advocate for changes in systems and structures. And so, again, when clinical care is not enough, how do you write op-eds, do podcasts, legislative advocacy demonstrations, and the like? I think this is where, physicians historically have not even voted as much as the general population. We've got to change that. Our voice is so important. And so also working to change structures as well. So I won't really share a lot about that other than I'm really proud of, there are race-based calculators, the way that I think I might see someone from nephrology or other healthcare fields here, but there was a race factor that was included in the way that our renal function that might have limited people getting put on a transplant list. So we were able to make that structural change at Emory across all of Emory and Grady. We changed the promotion packet and the CV writing so that to include diversity, equity, inclusion for everyone, so that everyone has to at least comment on what they're doing in the DEI space across the School of Medicine. So, so one of the ways I think that this exemplifies how diversity can be important is because, when diverse people get into positions of power, that they leverage their own experiences, my childhood experiences, my experiences in my profession to sort of say how we can change things to make the system better. And so getting more to what we can all do, and I'm sure everyone on this call either has voted or will vote, but I just want to make the case that there's emerging evidence that it is absolutely tied to health. A growing body of research says that voting is associated with better health outcomes. People who vote actually have better health outcomes. So please, please, please make sure that you vote. So I'm going to summarize here that unfortunately, bias is pervasive. It is the metaphorical air. We can't avoid it. It is impacting the clinical care that you receive, that we give, that I receive, and our professional spaces, whether it's in healthcare or in other industries. I believe that diversity itself can improve this. And even though we have 15 to 20% of our physicians, which is higher than the national average, we still don't represent the diversity that's in our Atlanta community. So in addition to diversity, we have to be more proactive and intentional to raise awareness for bias training and reflection, of course, but also changing those structures and systems and interventions that can really have a long-lasting legacy. And so I will leave you with this image. I am really proud of this. What I have tried to do over the course of my career, and have been just so honored to do this, is expand what a doctor looks like, what a professor, what a leader looks like, not just for our patients, but for our learners and our community. I think it's really important. And this image and this quote, the Lancet Journal is one of the most highly esteemed journals in all of medicine. And so one of my mentees, who's a fabulous colleague, Kimberly Manning, if you're on social media, you may know of her, Grady Doc. She wrote this article and she quoted me because I had been trying to get her promoted for like years, and she was nervous about it, and she finally did it. And what I said to her is what's here is, what if after you got promoted, the idea of what a full professor looks like and contributes is expanded because of you? And she had the idea, because of her social media savvy, to take this image in these bright colors of these beautiful Black women who were promoted to full professor. So with that, I'm going to end and open up the floor for any questions or thoughts or comments, and again, say thank you so much for this opportunity. I know I kind of sped through some things, but I would love to hear any comments that that folks have.
That was amazing. Thank you again so much. So everyone, feel free to drop your questions in the chat and I'll go ahead and read them out loud. If anybody's unable to type in the chat for some reason, please feel free to raise your hand with the Zoom reaction and I will make sure to unmute you. Okay, so the first question coming from the one and only Dominique Harper. Are there things we should be thinking about that is not talked about enough when it comes to choosing healthcare providers?
Yeah, I mean, I think that a couple things I would say to that. I do think that there's a fair amount of evidence that suggests that race concordant physicians could be helpful. I do think, because I work with a lot of physicians, I don't think that that has to be the only thing. I think that whether they, no matter what race or gender, what have you, that you want a physician who will listen to you, who will engage with you, again, as you all said, not just about the medical issue, but how it's impacting your life, to hear your concerns, and not blow them off. And so I think that that's really more important than anything. And I also think it's really important to advocate for yourself. There's also evidence that patients and families who ask more questions get better care. So, you know, to be a partner and to be present, I know that that's a privilege, right? So I know that when my mom was in the hospital, I was able to be there, you know, all day, every day. And that's not, you know, we have patients oftentimes where their family members can't get off work, but to the extent that you can engage on your behalf, ask questions, this is your care, you know, and if you're not getting the answers that you like, then, you know, by all means, you know, you have choices and to find an alternative care. So I think that's really important. And also, you know, we get a lot of referrals from people who have had good experiences. And so ask your friends, ask your neighbors, you know, if they are pleased with their physician. But mostly you want someone, I honestly think that, you know, the smartest people, it's great if you have the combination of a really smart person and somebody who can communicate. But sometimes even somebody who is an excellent, like the highly trained and, you know, critical thinker, but they can't talk to you, they can't explain, they don't listen to you, then that's not, that may not be the quote unquote best doctor, if that makes sense.
Absolutely. Makes a lot of sense. Thank you so much. Okay, our next question is, could AI clinical decision-making tools get rid of implicit bias?
Unfortunately, no. In fact, AI tools are just a mirror of what's already, you know, in that metaphorical air, right? So the bias is built into AI, and that's, in fact, for those of us who do this health equity work, we're trying to think about, like, what are ways, because AI is not going anywhere. It's being built into our clinical tools now. When you go to the doctor, AI might be scribing the notes for your physician. Physicians, you know, some of the patient education that we're generating may come from AI tools, but unfortunately, AI is only as good as the internet or the World Wide Web itself and all of the tools. And unfortunately, this legacy of racism and discrimination is imbued in that, so it's unavoidable still.
Makes sense. Thank you. Okay, Doc Flanagan, I'm coming to you next for your question.
I'm trying to get away from this sound outside. But two-part question is, one, what would you say would be one of your top buy-ins to the school and on board for the change coming in as a outsider? Right now, you know, there's a big discussion of the tipping point from Malcolm Gladwell and like what that number is to get to inhibit change. Secondly, how do you take the local change to a national level as far as like the School of Medicine goes across the country, other institutions, and what do you see as factors or barriers for doing that?
Yeah, I mean, I think for change, if you ask me, as someone who was in the med school class in 1988, and there were 8 Black students, and only 4 of us graduated, and I don't think there were any Latino students at that time. So, and now we have usually anywhere from 30 to 40, 20 to 40 Black students of color, Black and brown students. I'm like, oh my gosh, this is amazing. Along with all the other things that I was describing, but the students are still saying we're not going far enough, fast enough, right? So I think there's still, I just say that, as Martin Luther King said, the arc of justice is long, but I can't remember exactly. It bends towards justice. So I take the long game. I do feel like, for me, again, making the argument around, especially as a person of color, that I didn't get as far when I was talking about like, this is the right thing to do, but talking about the evidence about how this is going to improve patient care, how we're going to be a leader. Like the more Black and brown physicians that we have for this wonderfully diverse community in Atlanta, that's going to make Emory better. That's going to make Grady better. My clinical practice is at Grady. And so making those kinds of arguments, the learning environment, I mean, there's evidence around that too. So if we have more diverse students and faculty, that the learning environment is better. And so when you make those kinds of evidence-based arguments, I think that that's been a little easier rather than just sort of saying, do it because it's the right thing to do. I also feel like, what happened after George Floyd was meaningful, a lot of positive movement there, only for the pendulum to rapidly swing back. And so because people weren't really in it for the right reasons, but the institutions, I'm happy to say that Emory has stayed the course. But we're a private institution, and whereas a lot of my colleagues, my title no longer is specifically DEI, but I embed DEI into everything that I do. My chief role, my dean role, that kind of thing. But people who have had DEI positions have lost their jobs when I go to the national conferences and things like that. And so at a national level, I find that this is becoming even harder, to answer your question.
Thank you for sharing that. Okay, so our last two questions. One is, I feel more taken care of when the medical professionals are of color. Is it rude to ask for a change in my primary care physician or unprofessional?
No. I mean, if I think that you are the patient, and as a patient that you have a right to choose a physician based on who you connect with. I think that I believe as a primary care professional that it is a long-term relationship and partnership, and that you should have someone that you feel comfortable with, that listens to you. Perhaps my husband is a surgeon. He would hate it if I say this, but if you're going to a proceduralist to, have plastic surgery or some other procedure, maybe you don't think about sort of like how you connect with them and things like that. But your primary care doctor, you need to have, whether it's race or gender or just the communication, you need to pick someone that you can connect with.
Perfect, thank you. And then last but not least, do you have any advice for minority students interested in pursuing medicine when implicit bias can be so pervasive in admissions in the medical field?
Yeah, I mean, even now, I can say with the most recent legislation, they've taken away the opportunity to look at race as an indicator. So, for example, we were so interested in diversity in our residency program that we didn't let any number of a board score or a GPA. There was no number that was too low. They still might not get an interview, but at least we looked at every application of a person of color, right? So because they were the box checked, we would at least pull out to see if they got 1 point below the baseline, at least if there were other things in their application that made them like the most fabulous person ever, but they got a 249 instead of a 250, that cutoff, that we would still be able to look at their application. Now we can't do that. So there's no way that you can sort of single out someone based on race. But I still say, because for institutions who value it, which are probably the institutions that you want to be at, that you should still lean in on what makes you unique. Just like I tell that story about my personal background, and because we are looking for that, we use natural language processing in our personal statements. If people talk about their race, or if they talk about their experiences, we don't only care about race, we talk about distance traveled. So people who come from rural areas, having diversity of opinions and experiences expands the way that we can care for patients. For me, that's what it's about. if I have someone who everyone comes from the same background, it changes how we talk to each other in the profession, how we talk to our patients. And I believe that when people have these diverse experiences, that it lends itself to them being better health professionals. So we need you. I hope that you will continue to think about a career in medicine, and I would lean into, you know, your diversity and how it will lend itself to you being an even better physician.
Amazing. Well, I want to say thank you again, and thank you to everyone who is here. I want to pass it off to my amazing supervisor for 1 second to introduce himself. Ricardo, take it away.
Dominique, thank you. Everyone, I need you to know that Dominique planned this program, so please use your reactions to show her some love for putting the thought into kicking this off. And of course, our incredible presenter tonight, Dr. Bussey-Jones. This is a brand new endeavor for us, this virtual series of Black Emory programming. And to start with such an important topic, I mean, really sets the tone for the great conversations that we're going to have going forward. I just wanted a quick moment to plug the Black Emory Impact Circle. For those of you who haven't heard, it's a really unique opportunity at Emory, and if you are an Emory faculty, staff, or student, think this is going to be particularly interesting. And if you're an alum, I have a way for you to get involved. The Black Emory Impact Circle provides grants for faculty, staff, and student organizations to explore their big idea, to bring the Black community together, and to make sure that the dollars that have been raised go directly into causes that support and uplift the Black community. So as you're thinking about, you know, what are the resources that are available for Black folks on campus, I hope you'll think about the Black Emory Impact Circle as a place to go. Our applications for this new grant cycle open next week on November 1st, and they'll stay open through January 24th. If you have an idea about something that you want to do, please submit that, and we'll be sure to share that information in an email that we send out. To our alums that are on this call, thank you all so much for being here. The Black Emory Impact Circle is 100% funded by a small group of alums who are dedicated to making sure that Black Emory gets the support that they need. One of them is on the call now. I won't call you out because I didn't prepare you for that, but thank you for being here as well. But I invite you to join us in a way that feels comfortable for you. We will continue these virtual programs, so if you see an email for us, please join. If you would like to share your expertise, it doesn't have to be on medicine. It can be on a variety of things. We'd love to feature you. And then finally, of course, if you are interested in being philanthropically involved, then we hope that you'll consider us as well. Thank you all so much for being here this evening. I hope that you all have a good evening.
Happy homecoming. Everyone have a great day.
See some of y'all soon.